Hi, and welcome to Human Rights Here, Now. I'm Rachel Goodman, and today we take a look at the Death with Dignity Act, passed by the state of California very recently and put into effect. It's having mixed results in its implementation. We're going to learn from doctors and patients about how that law is actually coming to pass and what led up to its passage. Here with me to talk about that today are Dr. Catherine Sonquist-Forrest.
Hi.
She's a medical doctor with Stanford and also teaches in the medical profession. Thank you for being here. And in just a while, we'll speak with Peter, who is a patient who is facing some issues in his own life that have led him to consider what this act means to him. Later in the program, we'll be joined by Dr. Grube, and he is an expert in this field in the state of Oregon and works nationally on this issue and was very involved with helping it pass in California. So I'll start with a couple of really basic questions about it, Catherine, and then we'll get into some of the more nitty-gritty things that I mentioned. But let's just start by asking you, what is the act and what does it do for people?
Okay. The act explicitly is modeled after the Oregon Aid in Dying Act, and it allows patients that have a terminal disease, that is, that it's incurable, irreversible, and expected to cause death within 6 months, to choose to ask a physician to provide them with medical aid in dying if they're a California resident. The law was actually passed in the fall of 2015, and it was enacted in June of this year.
So that's quite recent. We're talking
very
months.
Within months, that's right. And the law's intent was to provide people who experienced their planning at the end of their life one option of how they might choose to live in the last days of their lives.
So it's about efficacy and choosing how you end, not hastening the process particularly.
It actually could hasten their death, but it doesn't. Was never intended for people to. It was intended for people at the end of their lives who have a terminal diagnosis. And there's swaths of people who it does not include. It does not include people who can't ingest the medication on their own, for instance, or that aren't competent to make a decision. So, for instance, it excludes people with dementia. So it is a narrowish range of people who, for whatever reasons that they define for themselves, provide them with the option to have death with dignity at that stage. Dignity is not the perfect word for it, because what it really allows them to do is to have some control over the conditions and the timing of their death.
So let's talk about the circumstances that led to this passage. Some of the stories people were hearing that led to the request for this ability in our state.
Okay.
Some stories perhaps of people that said, you know, my quality of life is horrible, and nothing the medical profession can do can make me feel any better. So those were some of the stories I heard, but I'm sure you have many in the profession.
I think that many people who practice medicine do. I've been a family physician for over 20 years. The first time that I was asked for assistance for aid in dying was actually with one of my AIDS patients very early in my practice. And I think many of us were asked that and didn't have the capacity within our scope of practice to do so. These were people that for whatever reason were suffering, either physically suffering or didn't imagine that they wanted this to be the end of their life, or in some ways imagined a different end. More recently, there's been several attempts to pass this law in California. I'm remembering about 10 years ago, I had a patient who actually was a judge in California. I have permission to tell this story from his widow, who is an elected official. He had a terminal disease. He had been in palliative care. He had been in hospice care. He was actually not in pain, but the trajectory for the last months of his life were going to be one of increasing medications to deal with the pain, and also probably loss of function in a way that was intolerable to him. He experienced that as suffering. At that time, he was trying to actually move himself to Oregon, which functionally was very hard for him, and he ended up dying here in California. But he had come to me to ask me if I could help him. And of course, at that time, it was not legal. It's stories like his that have led now to the passage. The very famous case of Brittany Maynard that made the press was not dissimilar, a series of things that would be happening in her life that described for her a life in the very end of her life that was not the life that the way that she would like to live the end of her life, and she chose to move to Oregon.
So she moved to Oregon and did get assist
Yes.
for the end of her life, and that was a big story that maybe inspired the lawmakers in our
I believe
community
so.
to get brave about it. I have a personal story that I feel okay about telling because it needs to be destigmatized. I think that it's wonderful that we can even have this show, and it's a difficult topic. No one wants to die, no one wants to hasten their demise unless they're facing something awful, much worse than death. And most of us, that's, a hugely personal decision, as are things about abortion and other, really difficult junctures. My grandmother had pancreatic cancer, and she was 88 and was in horrible pain, and it was not going to get better, and she was on massive doses of morphine. And she actually had been stockpiling it, being in pain so that she could save up enough to end her life. And she ended up being unsuccessful and had much more pain at the end, and asked family members to help her. And what happened in those circumstances for my father was he was put in this awful position of having his own mother beg him to end her life. So how many people are in that story who asked for this bill to pass? I think a lot more than would say it publicly. That's a private thing that they aren't willing to talk about. But for most people, you want to show love in whatever way you can, and if love is the cessation of suffering, that's a really brave kind of love. And now doctors are being given that incredible role. In the Hippocratic Oath, that's not probably what you teach in medical school. Maybe it is, but this is one of the ones they probably didn't discuss.
It's complex because the people that are involved here are not people that we're going to be curing. This is people that we're caring for. It's not dissimilar in many ways to palliative care or hospice. It is, how do we want to help someone live in the time they have? What kind of care do they need and want? And in some ways, the Hippocratic Oath, which actually the modified Hippocratic Oath includes helping and not only not harming, which is the oath I took at UC San Francisco, it actually fits within it because it has to do with alleviating suffering. Hippocrates lived long before we had the ability to extend life for months and months and years even. So the modified oath, I think, speaks more to this, which is how can we alleviate suffering, as it's, as you pointed out, individually defined by a human. And the option doesn't say that you have to do this. It makes it possible both for physicians to choose to participate and for patients to choose to request. Some of what the complexities have been is that we don't have a way to match up those yet. It's so new and so complicated in our state. The diversity of our state makes that, the complexity of that, tremendous.
So I want to take one piece of that, which seems like the toughest part, which is the conscious communication of the wishes of the patients. Most of us, if we get to the point where we're suffering that bad, may not be able to communicate well. I'm thinking of my husband's mother, who had a stroke and was being tube fed, and at one point it just seemed like this is not the way she wanted to be, and they communicated it, and she was able to say, I want to stop doing this now. But it was a very difficult end. It was before this bill. And so they basically took her off feeding and water. And that's a really not very comfortable way, I would think, to end. It takes a long time. So she was able to communicate. And if this law had been in place, she would have not had to suffer for a couple of weeks like that. And the family watching was probably as hard. So, I guess I would say, how do you ascertain, that the person's will is being expressed?
First of all, my heart goes out to the family because they're trying to navigate what would somebody want, what does somebody want, and my heart goes out to them. I think one of the things that's been so remarkable in one of our teachings from the states that have gone before us, Oregon and Washington in particular, is that the ability to have this conversation awakens and enhances the other conversation, which is, what might you want at the end of your life before it's in front of you? Not that any of us knows our time, but hopefully we're beginning to have that conversation in a more poignant way. So planning for that, there's some documents and some applications to help people do that. 5 wishes comes to mind. For people to be able to think about, what might I want if I'm in that situation? And it could include this kind of conversation. You cannot say, I want this to happen to me. It has to happen actually in real time, and the law is quite specific about what the procedure is. But it opens the conversation. So one of the things I'm doing, and we're doing actually across the state of California, is training around difficult conversations, end-of-life conversations. And no one wants to have the conversation, right? You know, I have people come into my office. I'm a family physician. I see people birth to death. And so I have a middle-aged person coming in. I'm saying, you know, let's have this conversation. And it's complicated. On the other hand, people are very grateful. And families, however you define them, are terrifically grateful if you have something left of what it is that you desire. So that's one of the things that is an added benefit of this legislation, is it leads people to have those really crucial conversations. And then if a patient is in a situation where they are able to make these informed consent, then they could include this option. Might you want to conclude medical aid in dying?
So if they do it before they get too ill to speak, it still could happen? Or do they have to be able to speak their will in order for this to, for the doctor to prescribe these so-called end-of-life drugs? I don't know how you're referring to them.
Yeah, they need to be able to communicate. And
writing or blinking or...
More than blinking, they have to be able to show competence in decision-making. And this isn't new to medical profession. We do this all the time. Are you competent to make a decision for surgery? Are you competent for chemotherapy? Are you competent for any number of things? This isn't new. That part's not new.
Right.
What's new is the finality of it, and to make sure that all the safeguards are in place, and we need to honor them for there to be no coercion at all.
Sure.
And for the most part, you know, the other states have shown us that it's a very small subset of people that this is appropriate for or that desire this, and it's the knowing that it's there is one of the most important things.
I was reading about that in Oregon, that so few people actually carried it through, but that the actual presence in their hand of the drugs that they could use made their pain less because they thought of permanent suffering was gone. You know, pain, I mean, you could tell me more about that than I could ever tell you, because it's an individual experience, and you want out of it if it's really bad.
Yeah.
It's really, really hard to just believe that it can go on and on, you could survive, because the human brain says, let me out of here, right, and stop this thing.
Right.
So that isn't the best moment, I would imagine, to make a very calm decision.
Again, the training helps us here. If somebody says that, then I'm going to lean in and we'll have more of a conversation, because it turns out that there's good tools. If what your concern is pain or loss of function, and that's what's leading you, then we can lean in and say, well, let's talk about what the tools are. Are we dealing with your pain? Have we talked about what your fears are for your family? So we can lean in and really get into what are the other issues for the person, because while there's not perfect tools, there's much better tools than people imagine, and there's not a reason for people to be suffering. But they might not know that because the conversation hasn't been opened.
Right.
They're hard conversations to have. In medicine today, we can do a lot to alleviate people's discomfort, pain, even fear. But there's also this option. So once we get in there into their innermost concerns, we can sift out what needs to happen next.
It's very complicated. I did want to bring in another voice into our
Okay.
conversation because we do have someone who's struggling with some medical issues, and
Okay.
we often don't hear from patients as much on this, although we heard a lot from people who are suffering when the bill was being debated. So I wanted to bring Peter into the conversation.
Hi,
He
Rachel.
chose to be off camera, but his voice will be heard, and I respect his wishes to remain a private person in the community. But Peter, if you don't mind sharing your story a little with us and why you're thinking, what's your relationship to this act, and how do you feel about the conversation so far that you've been listening to?
Sure. So my personal situation is that I was going along with a vibrant work life and was diagnosed with melanoma. And it turned out that my doctor missed it, my dermatologist, twice. So it was an atypical melanoma, not what you typically see. And in December, he said it was nothing. In March, when I went back to have it taken out, he said, oh, we didn't have it long enough, but don't worry, it's nothing, but we'll take it out in April. At that time, they did a section. They thought they had it, but a year and a half later, it was throughout my body. So I literally had a tumor the size of a football with a nose cut off, and tumors through the liver, lungs, mesentery, spine, etc. So at that point, I was given this sort of 6 months to live, kind of prognosis. So it was a time with my wife to make sure financial things were in order. I happened to have, in addition to the cancer gene, the tool gene, so I sold 19 of my favorite hobby tools, big things. So that was the thing, but then I began fighting this thing. And throughout that whole process, a sense of dignity, control, mastery of my own decisions was absolutely key for me. And so I've actually been through every litany of treatment you can imagine. I'm one of those people who's actually read the ACA. And to me, this act, the most important thing of it is this sense of control. So you have this question of what's my next treatment? Am I in charge of that, or is the doctor? Do I understand it? What are my options? And just having that option, I think, is very important to people. I would say too, that's not for everyone. There are some people who would say, I will never take my life. I will go, and certainly I was willing to go through great pain, but I also wanted this sense of control. I'm a member of a group, Ollie in Santa Cruz, that has the most vibrant older folks you could imagine. And we actually had a discussion on this very topic in one of the times. And it was interesting that unanimous amongst these vibrant people, but all old enough to be, one of our members died the other day, was the desire to have this sense of control. So I would say that having the discussion is one of the most important things of it. Something you didn't mention too is that most of us, if we decided we could wanted to commit suicide, that was the only way out, could find a way to do that. If the act is one that is, there's this whole gray area of, you're not quite capable of committing the suicide if you did it. Well, you're not capable of following through on the act either. I mean, there's this gray area of people who might wish to do it. But one of the things it does is that for those people who are young in their lives and have insurance, it lets that insurance stay in place. And so that's an important, it allows that conversation. So people aren't going, well, I have to commit suicide and I'll run a car off the cliff or something. It's a kind of a cleaner way of dealing with one of the toughest decisions possible.
Absolutely.
Obviously, I'm here living happily past my expiration date.
Happy to see
I
you
fought
today.
the cancer. That was my path.
Right.
But knowing that was an option even before this law was something that did give me a sense of control.
Let me ask you one other thing, and
Sure.
then I'm going to kick it back to Dr. Forrest, which is, what was the conversation like with your doctor when you had decided to ask for this as an option?
Well, I didn't decide to ask for it.
Oh.
This was all the only person I would even consider talking about this was my wife.
Okay.
And I was going to exhaust all of the possible remedies and things like that. At the time before this wasn't something that doctors felt comfortable discussing.
So you wouldn't have brought it up?
No, I never brought it up.
Okay.
It was just one of the thoughts that like tumbleweeds went across my head and was there, even without the law as a possibility if I felt that things got to that point.
Well, thank you, Peter, for
Sure.
sharing that story. I really appreciate you being here. We'll get back to you in a moment with some other questions. But this brings me to an article I read in the Santa Cruz Sentinel that really struck me, which was the law has passed, and yet it's so early and we said 3 or 4 months, right, or 5 months, that most physicians are unable or unwilling yet to offer this to their patients. In this story, anyway, this woman's mother was quite ill and had been promised by doctors that they would offer this to her. And then in the end, they reneged on their promise, which was really sad. So it wasn't the death she had been promised by the law. And I don't think that's the only case like that, but there's also some that have turned out well. And I understand there's a physician in Berkeley named Lonnie Shabelson who is taking patients from all over the state. So it's not like there's nowhere to go, but for this woman, she didn't have the luxury to go to Oregon, and we had the law, so she thought she was safe.
Right. Well, a couple of things. One is that I think the law itself does not promise anyone access. It decriminalizes the prescribing physician. It doesn't require the physician to prescribe. It's only physicians and none of the allied health professionals, so not nurse practitioners, not PAs, just MDs or DOs. And it specifically doesn't say that you have access. It does not provide for access, which is one of the big problems with it. It also allowed physician groups to opt out on behalf of all the physicians. So if you are in a physician group that opts out, for instance, in our community, Dignity is an opt-out community health system. Any doctors that work for Dignity are prohibited from prescribing at their place of employment.
Even though it's legal, even though the law says it's not going to be anything they have to worry about as far as legal goes.
A system can opt out, and all the physicians that work under that system would have to go to a different employment in order to prescribe. This is by the way, the same as abortion has been for a long time. This is not new. So, but it just kind of highlights the access issue, doesn't it? The opt-in physician groups or private physicians can opt in. You have to announce that you're going to do that, but the opt-ins are also large groups. So opt-in groups in our community are Sutter, or Palo Alto Medical Foundation, and also the PMG is an opt-in. And what that means is that any individual physician could make a decision, yay or nay.
But they don't have to either.
They don't have to
even though
either.
there's opt-in.
Which brings us to the next barrier. So what are the barriers? So the barriers are, this is a new area of practice. It's brand new. None of us were trained to do this care. And even trying to get instruction of how do you do this? How do we train ourselves to do something that's new? It turns out it's complex. Right, so that's one of the things that we've been doing in the community is individually, we think nationwide, something on the order of 1/3 of physicians believe that this is work that they would like to include. That's not everybody. And then of those, are you in a group that will allow you to do that? And then do you have the support you need to be able to do so with, I'm going to use the word excellence here, with excellence, right? So to feel confident in that care. And what we've seen is that it's very difficult, and I'm not speaking on behalf of my organization here, I'm speaking as an individual. It's very difficult to step forward into a new area here. It's been hard for individuals to speak, and it's very hard for physicians to speak. So we have not seen, there's not a list, you can't find who does this, unless you're somebody like Dr. Shelson in Berkeley, but almost no one in the groups. There's no individual groups. In my own institution, it's very quiet. Who does what? And there's concern about tourism around this, as there was in Berkeley. In other words, coming to a practice or coming to an area just for the purposes of this law. I raise this for the purposes of compassion on the side of the medical profession that's trying to adapt to new scope of practice. And we know from what happened in Oregon and Washington that it took a while for things to settle down. It took a ridiculously long time. So,
how long is long?
A couple of years.
Wow.
And
okay, so
for people to sort of figure out and put procedures in place. I mean, we put procedures into place. We weren't even sure we were going to be an opt-in. The academic institutions several of them have new things above and beyond the law in our state. So it's interesting to see how this flies. And I think on the patient side, how incredibly sad and disappointing. If this was what you're looking forward to as I'm ready now, because that's where you are in life, at end of life or approaching where you might like to consider it. It looks kind of bleak out there.
Right, and it's not like anybody would be making that personal decision very lightly, and to have mustered up your courage for it and then found it wasn't really an option.
Shut down, yeah, shut down.
That's got to be tough.
I think it is, and you know,
Yeah.
again, I can tell you stories. We've had people that have gone in within my own institution. We had a patient who tried to talk to their family physician, and that family physician wasn't comfortable. And since we didn't keep a list, there was this kind of this questioning, well, who does? Does anyone know who does? That happens, and I'm sure that that's going to be happening all over the state until there's a little bit of more ease here. And it's not dissimilar, if you think about it, to talking within your family. Who's in, who's out? It's a little bit of that, of trying to see who's comfortable with something that is really has some newness to it in our state. When I talk to my colleagues in Oregon or Washington, they've got a decade behind them, and it's a little easier.
Right. So I wanted to talk about some of the barriers for them. I mean, there's the worry that maybe you're doing something that is immoral to your religion. All those are more understandable in some ways. But this one where you think about, they're worried about bad press, or their other patients, thinking they are going to prescribe this. I don't know what the stigma is, but it's certainly, because it's so new, they're just imagining the worst possible things that could happen. Dr. Kevorkian was called Dr. Death. Was not a very acceptable thing to do in society. And even though you say a third of physicians are more than willing, they may not be actually actively offering.
Yeah. I mean, when I talk to my physician colleagues, again, I train on this. I think all of us want our patients to have hope.
Right.
We want our patients to feel supported. We want them to know that we're there right until the end, of their life. And we actually don't know what the end is. There might be, as our patient in the audience says, there might be treatments that extend life. We're not that great at this, but there might not be. And we do a reasonably good job at prognosis in some areas, but not in others. So that's a shift in paradigm. It's a shift in paradigm to say, okay, this is reasonable. Again, we do it all the time. There are people who refuse treatment, and that sends them down a pathway that we know doesn't have an ending other than death. And this isn't different in a way, but it does hasten. It just puts us in a different position. So
Right.
Those are the complicated conversations.
And it kind of skirts something you kind of mentioned, which is and you mentioned it earlier a little while ago, the end of life. We've extended people's lifespans, but not necessarily the quality of their life. And the number of interventions has risen for elderly in particular. I've seen people recommend operating on 90-year-old people, and but the 90's the new 80. But at a certain point, what are you doing? Why are you doing it? What are they going to come back and do after that, except be in a hospital bed?
Right. Well, that's a more difficult conversation to have often, which is, what is the quality of life? Right. That's why I think that the question of what can I expect? What can I expect the quality of my life will be? And we can do some of that, the royal we, the physician we can do some of that, but not perfectly. And particularly, I think there are many people that would be very vital and their life expectation is very vital after that point, at various points, and some that aren't. But so that's where it's very individual and hard to characterize.
It so is. Every story that seems like a perfect candidate for this, because look, their life is so bad. I think of my mother's friend, Sarah, who's 98, and she had a fall and, broke pieces of herself and went into rehab, and she came back from what everyone thought was the end, because we hear so much about that. And when we saw her in the hospital bed in the state facility, in the SNF, I was thinking, this doesn't look so good. She's 98. Right. But lo and behold, they had her up and walking, and she's so determined to do everything for herself. She's going to, who knows how long, but at least she's up and walking, which is what she loves to do. And who are we to say, you should stop now? right? It's really
I don't think it's up to,
No,
I don't
not
think it's
about-
up to us. That's why I think the conversation is so crucial of teaching, continuing that teaching of what is it that you want? What is it that you desire? And then honestly trying to take a look at what's possible, including now this option, which is new to us. The conversations are not new to us.
Right.
We just weren't as good at it as we could be, and in medicine, and I think in our society. But now we have a new option, which is tricky because it's one of the ones that doesn't have a branching point. If you go down this pathway and you hasten at a prognosis of 6 months, it closes options. And most of the time, most of us want to leave options open. We're trained to think that way in medicine. If we do this, it leaves this, and open. And it's hard to go down the pathway of caring, saying, okay, this is the constraint. We're going to take, just draw the boundaries here and support you in your happiness and your life this way rather than these options. And I think it's a paradigm shift.
It really sounds like it. Amazing, different thinking. The other obstacle you had mentioned before we started recording was the payment aspect, what's available to it. I don't know how much it costs. What does it cost for someone who has made this decision if they were to pay out of pocket? Do you have any range of guesses?
Absolutely. So I want to talk about the obstacles and then the costs. The obstacles I think that none of us really got a handle on early on was that federal funding precludes payment. So if you have Medicare does not pay for the medication, and the cost has been going up and up and up in the last 5 years for Washington and Oregon, and then also here. Medicaid, which is Medi-Cal in our state, has a carve-out. Governor Brown made a carve-out to cover the medications for people on that. The VA also has a carve-out because it's federal funding, and since it's not legal in every state, it can't be covered here. That's not different, by the way. Again, abortion is not a bad analogy for much of this, but that's a huge swath of the population, including many people that are over 65. So it's a big swath of insured population.
Any idea how many people that would exclude? I mean, it seems like most people who get cancer tend to get it in their later years. That's just the way cancer works. It takes a while to manifest.
Yeah, the more common diagnoses are cancer, AIDS, and neurological problems where you still have cognitive function like ALS. I don't know the numbers off the top of my head.
So it's a big group.
It's a big group.
Is there work trying to expand that coverage? I mean, there was with the other things you were talking about. It's still a controversial topic.
I don't know about that. I'll be interested to see if Dr. Grube might be able to help us with that later on. But the cost has been really an issue, and the cost of the original medication being used in the Northwest was originally around $500, but went up to about almost $4,000 or $5,000, and that was really prohibitive for many people. So the physicians in Washington have been working on protocols that work, that are reliable and work over the last, I would say, 12 months, and released new protocols in January that are used within the context of their Death with Dignity law that cost about $400 in this state today.
So I'm going to ask Peter another question while you get
Okay.
Dr. Grube on the phone, if you don't mind, and just push that button. So I want to include you back into the conversation. I'm sorry to leave you out for the moment, but having you back. When you listen to this conversation about California and Oregon, do you know of other people who talk about this with you and discuss what might be the optimal thing to have for patients who are considering their options?
Your call cannot be completed.
Sorry.
Try no one. There you go.
So I've talked to a number of patients with cancer who want to know, how do I start dealing with this? And what I would say is that the greatest gift you can give someone facing death
Hello, this is David Grube.
is to give them the sense.
We're right here.
Hi, David.
So
We're-
sorry. Hold that thought. I'm
Sorry.
We just got our caller, so we're going to just have you hold
I'm
that
sorry, I
thought.
misunderstood.
Dr. Grube, we have a patient here, Peter, who's just talking about discussing with other patients what would be optimal. And I'm going to let him finish his sentence, and then we're going to get you on. So just hang there for just a second. This is very high tech.
So what I was going to say is that the people that I see surviving are the ones that have a sense of control and decision. You have a choice in our medical system of being a pincushion. And I was being dripped 7 days a week, 24, with 8 different chemicals dripping into me. But retaining some sense of I have choices.
Right.
Is very important. And I think what this law gives is people have one more choice, one more sense of control. Most will probably not choose to exercise it, but giving them the sense that you're a free person, master of your own destiny, what are you going to do next, is one of the great gifts of the law.
Wonderful. Well, thank you for that. And we're joined now by telephone by Dr. David Grube. He's an organ family physician and helped 30 terminally ill people die. He is part of Compassion and Choices, which is the main advocacy group that has forwarded these laws in many states, including Oregon, California. And Dr. Grube, I was going to ask you if there are laws about to be passed in other states right now. Are we on the cusp of a whole wave of them, or what's going on in the bigger world?
Well, yes, we're on the cusp of a wave. I just returned last night from Colorado, and they have a Proposition 106, which will be voted on in the Tuesday in November. It looks very probable that will be passed because polls look like it's overwhelmingly supported by Colorado citizens. New Jersey and Washington, D.C. last week in their legislative bodies passed out of committee End-of-Life Option Act bills to be discussed in their legislature. So those two also may very soon pass this legislation. Also, New York is discussing it actively, as is Massachusetts and Minnesota. And I think in total right now there are varying degrees of discussion, but 30 states above and beyond the 5 that are currently authorized are looking at this very seriously.
Thank you. That sounds like there is a wave going on. What would you say needs to happen for this to be a federally supported law, or do you think that is the next step after enough states embrace this by referendum, which sounds like what you're saying is that legislatures are not touching this, they're letting the citizens put them out, or groups like yours put them out as referenda?
No, then perhaps I didn't make myself clear. As in California, both in New Jersey and in Washington, D.C., this is through the legislature.
Okay.
Also in New York and also in Minnesota. Only a few states, I'm not sure, maybe only about half the states have a initiative, a referendum process, so that isn't possible in some states.
Okay, so back to my federal question. Do you think that there's a critical mass building for a federal law that would make this more accessible to most people in this United States?
Absolutely do. I think there's 2 paths. One, of course, would be a Supreme Court ruling that it's not illegal, and that's what happened in Montana, of course, because while Montana it did not pass a law or an initiative, the Supreme Court in Montana said it's not illegal, and so it happens now in Montana. Mm-hmm. That would be probably the quickest and smoothest way, but with enough support, it certainly could go through the Senate and House on the federal level.
Are there other types of federal-state schisms that this reminds you of? Is it like medical or recreational marijuana, or is it like abortion? Is there any other path we've trod where the state laws don't match the federal, where they just have to get in sync eventually?
Well, the closest one, I think, is marriage equality. That's, it was there was a certain tipping point when everybody's realized that, like slavery, why have we been not allowing people that love one another to have some sort of a bond? So I think that would be if there's a model that you would compare it to, I would say marriage equality.
Great Great analogy. So I'm going to let Catherine ask a few questions too, but I had one, which is in California, it sounds like there's some stumbling blocks. We've been discussing them, not just the stumbling blocks, but also the positive things it's offering people. Being that you've watched it in Oregon for all these years and seen it get easier, what kind of educational processes are going on to get physicians to where they feel more comfortable being part of it? Because it sounds like some of them just aren't yet.
Well, in every level, it's happening. We have 2 medical schools in our state, and it's it is part of the curriculum in both medical schools. So it starts there. So all the new physicians who are coming out now understand what the law is and their professional duty to respond to their patients' requests. On a regional level, there are educational programs, which we call in medicine continuing medical education programs, through medical societies, through grand rounds in hospitals. Big educational processes going on through hospices. And I just returned from an educational program in a community college in Central Oregon. So it's happening in a collegiate level and community college level as well. So in all levels, people want information, and it's happening all over the place.
Dr. Grube, this is Dr. Forrest. I wanted to both publicly thank you for your assistance in the state of California on behalf of the physician groups, but also personally for your assistance in helping educate family physicians through the California Academy of Family Physicians and Compassionate Choices. Thank you.
You're most welcome.
One of the big barriers that I'm seeing now as I do education across the state is physicians now know something about the law, but very little about the process. So educating about the actual process. And I'm wondering whether or not one of the questions that comes to me sometimes is, how long did it take in Washington and Oregon for there to be some ease among the physician groups, that people started to speak more about it and you started to see more physicians engage and prescribe?
Well, it does take some time, and I think each individual physician, as you know, since you are doing this work there, has to kind of come to a personal understanding in their own heart about how they can participate or not in this thing that their patients are asking. So it took a few years, and it's still taking years. I mean, doctors are changing. If you look at the Oregon statistics, every year a few more doctors are prescribing. So
would you mind me asking how many right now? Sorry to interrupt, but I was curious if we have any numbers on either state about how many, because they're not coming out publicly in a list. So
yeah, it is. If you look at I think 108 doctors in Oregon last year wrote, or maybe it was 130, somewhere over 100, less than 150. And each year it grows by a certain number, certain percentage, 5 to 10% each year. But the statistics are available on the State of Oregon website and the State of Washington website for where you look at the public health statistics.
California will release its statistics in July of 2017. If you try and get information now, even though I personally know of multiple cases, including close colleagues of mine, that data is not available in a collected way yet, and we will get our first report in July of 2017, and that will give us more information about who's asking, who's prescribing, not by name, of course, but by collected numbers and where distributed across the state they are.
I imagine
by diagnosis as well.
If you're ill and you go to your family physician or whoever your existing physician is, that's the first question a patient considering this would ask is, would you do it? And then they would ask, if you wouldn't do it, what do I do now? And that's what they're scrambling for, right, is referrals.
We know that that is happening, that there are people who go to their physician or their treating physician, and then the question becomes, if that person is not willing to prescribe or not, maybe not even have the conversation, what next? And again, I'm appreciative of the longer view of that does not mean it won't happen. But it means that there's room for, it's an opportunity. It's an opportunity for education for all of us. And I would always encourage if somebody runs up against a roadblock or a barrier, to let the health plan know, I'm seeking this, help me, because most of this needs to be operationalized. There's a policy in place. How are you going to help me find someone else? The policy at my institution actually has a system for finding someone else, but I'm not sure that most do. And that's what Compassionate Choices has been helping us with. That's what the California Academy of Family Physicians is trying to figure out. How do we build these policies so that people feel supported when they make their own choice to participate or not participate, all the way through, in patients and their families, as well as the physicians and physician groups.
I would like to say a little something here, and I encourage patients and citizens who are listening to your program to do what is called the early ask, and that's to speak with your family physician, even if you're perfectly well, to say, how did Dr. Forrest, how do you feel about the California's End of Life Option Act? If I were ever to get terminally ill, and what would you be there for me? It really is important because it stimulates doctors who haven't thought about it, or ones who are beginning to think about it, or ones who've been thinking about it for a while, to come to some conclusions. There are no statistics that are kept in Oregon, couldn't really be kept, about people talking to their doctor just on a very informal level. But let me tell you, as a family physician who practiced here in Oregon for 35 years, and 20 of those while we had our law, lots of different patients would say to me, Dr. Grube, how do you think about the Death with Dignity law? Even when they were well. And I think that really has a snowball effect also, to talk with your doctor when you're not sick. It just makes the doctor understand that this is something that's really patient-driven.
Is there anything we can learn from the process of when abortion became legal in this country? It must have been rather similar objections and pressures, but also the advocacy for women who were trying this, legally for the first time. It seems like we maybe don't have to start from nothing, because there were protocols put in place for clinics to help people seek, this service that was now their right. Mm-hmm. I know that we're not talking about a right that's universal in the country yet, but we are talking about seeking something that is legal.
I think that the parallels are terrific, and I've spoken with people. I mean, my practice posts, that I was not a physician at the time of that change in practice and legalizing of that scope of practice. But when I talked to older physicians it was a tremendous shift in thinking about it to what had been not being able to discuss as something that was legal and possible for patients to be able to talk about it and to start putting the referral networks together. And it's very similar. While some people might be in favor, they might not choose to participate, and some don't even want to talk about referral because they didn't believe in the option. And we're still seeing that range of philosophical belief or ethical belief about this. So I think that the parallels are similar, and the importance of that is compassion, of course. If it's something that it's not okay for you, does that mean that you get to make that choice for someone else? It really is a choice, kind of an issue. And what we found in our own medical networks is that it became consumer driven for women to be able to find other women to support them in their choice. And now we're seeing that somewhat with our patients. I think our patient Pete was talking about talking with other people that are in a similar situation, and just the power of knowing that you have the choice. Other people may or may not make the same choice, but being able to talk about it and what you might be able to do. We don't have the networks of what to do yet. That's still in play. Yeah. But that piece about the supporting someone's desire within what is their choice under the law in the state of California is pretty powerful, and I expect that we'll see similar things transpire.
Dr. Grube, do you have a comment about that as well?
I think there are parallels, and I think there are, in some areas, absolutely no parallels. I mean, in this topic that we're talking about mostly today, end of life, it's a universal question for all people, not just in abortion. It's mostly women are seeking support, although sometimes it's family support. But everyone's going to die. We're all going to die. It's getting more complicated to die, and really this is, to me, a much more universal question, the end-of-life option discussion. There are parallels, I agree, but in other ways, this is a much bigger issue, I think.
I think what you're touching on is that in Western society, anyway, we do absolutely everything we can to thwart death to the very last second. And so this opens up a new conversation about when is it okay when the patient themselves is done, and how much credence to give them. And one of we have only a few more minutes left, but this is kind of a big question. Hopefully you both can tackle it. How much do you train physicians to inquire and discuss in a totally non-coercive way? Because the law says no coercion, but there's such subtle, the information about their diagnosis isn't coercion, but it's not 100% guaranteed that they will die. And when Pete was talking about his story, I'm thinking, yeah, but he lived a lot longer than the doctors told him he would. And in fact, looks pretty healthy right now. So it's not just the medical information, but it's how you present it, right? So is there training about how do you become as neutral as you can with the information?
Yeah.
Wow.
Well, there is training, and more training now than when I went to medical school. And there's whole lectures on shared medical decision making and how to apply informed consent. But I think there was a study that came out came out yesterday from some Yale researchers about how doctors influence their patient's choice and their presentation of information based on their own personal beliefs and political persuasions. It was a very discouraging article to read, but you're absolutely correct.
How about you, Catherine? Do you have a story about having to be neutral as possible when giving a terminal diagnosis?
Yeah. I mean, this is something I experience all the time. I work in the belly of the beast. I work at Stanford, where people have advanced cancers and complex medical problems, and dancing that dance of this is what we think, and there are some possibilities, and you have these choices, and just holding what their hope might be and what their energy is for engaging in what might work and what might not work is complicated. They're really serious conversations, and our training is variable. So the training that I have or that family physicians have is a little different than that for internal medicine or for one of the surgical specialties or for one of the medical subspecialties like oncology or neurology. So I think the good thing is that the hotlighting of this issue is moving us all along. And it's rare to go to a continuing medical education of any field within medicine and not have some conversations that touch on this now. And that's a good thing. It's a good thing to have some conversations about the limits and the boundaries. I know that in Santa Cruz County, these conversations have been moving forward. There's a continuing medical education that's sponsored by the Central California Alliance for Health and the Health Improvement Partnership in Hospice that I'm participating with someone from the Atul Gawande group that's on crucial conversations exactly on this, on serious and terminal illness. That's at the end of October, beginning of November in Monterey and in Merced. So we're all kind of pushing the conversation of how to have the conversation, and I think I wish it was being driven by the physicians, but to be honest with you, it's being driven by our patients. And with all humility, I'm grateful. I think it's good for our field and for our society to be asking these tough questions of what is pushed on us as humans and what is available to us and what might we choose amongst the options.
The other thing this reminds me of, if I might make a little editorial comment, and it's in a more positive sphere of life is women choosing how they want the birth of their children to go, and really making a lot of decisions about what they wanted to have happen. This is all about patients kind of saying, these are crucial moments of life: death, birth, ending life. So we want to have a say, and we don't want to just be passive anymore, and that's huge.
Yes.
It's a real positive thing. We just have a couple minutes left, so maybe if each of you would say something. Dr. Grube, I'll give you first shot at just like a minute of closing if you have something else you'd like to share with our audience.
Well, thank you very much for inviting me to speak with you and be with you this afternoon. This is wonderful that you're presenting this topic and we're having these conversations about end-of-life issues. We don't like to talk about death, but I learned a long time ago that death really isn't the enemy of either the doctor or the patient, but the enemy is suffering. So whatever we can do to diminish suffering would be what I would hope could happen. And as I always say, since we've passed our Death with Dignity Act in Oregon, more people have not died, but fewer people have suffered.
Wonderful. Thank you. Thank you so much for being here and about that. And Pete, would you like to say anything in closing, very short?
I think it's a great discussion.
Thank you for
Thanks.
being here. I
Sure.
really appreciate the patient perspective in this. And Dr. Forrest, thank you for being here. It's been a really good conversation.
My
We have a
pleasure.
couple of minutes to wrap up with final thoughts.
I'm grateful for the opportunity to continue these conversations. I think all of us had a concept that it would be an easier rollout because it had been done before. So to find the barriers and then to work on how are we going to extend the option in a way that feels safe and that is accessible to all, regardless of insurance. Has really been a challenge, and it's just a reminder of the true access problem that we have in California, which is insurance and access to people that are well trained in any particular scope of practice. So for me, it's been very humbling, and I'm grateful for the opportunity to continue to talk about it. I did want to share one thing, which is that I did have a patient about 9 years ago, my own personal story on this, who had asked and was trying to move to Oregon and for resource reasons was not able to, and asked me if I would consider working on this bill, which was being talked about at the time. It's a local person here in Santa Cruz. And at that time, I was attendant at her death, and was there holding her hand when she died. And at her time.
Right.
And she asked if I would step forward, and on behalf of everyone who was never able to have someone have this option, I'm grateful to be here stepping forward, and thank you for the opportunity to speak.
Thank you for being in the vanguard. It's never easy to be the front of change, and I think you're among many people in history who have stepped forward, and thank you, Dr. Forrest, for doing that.
Thank you.
I'm Rachel Goodman. Thank you for watching this important conversation.
Thank you.